I have no financial disclosures. I'd like to point out that there is a companion video to this talk. It's a procedural sedation video that I did for the New England Journal of Medicine that was published in April 2014. And this illustrates with images and augments what we will be discussing today. There are 5 areas that we're going to cover today. Indications, that is, we'll review the most common to the least common procedures that procedural sedation is used for. The pre-sedation preparation, where we'll do a risk assessment and try to determine which patients are at high risk for sedation and which patients are at low risk for adverse events from sedation. We'll discuss the Pharmacopoeia, talking about the routes of administration of the drugs and the indications for the use of the drugs. We'll talk about post-sedation, both recovery and discharge, and we'll talk a little bit about future directions of the field of procedural sedation. I'm going to start with a definition. Procedural sedation analgesia is the pharmacologic management of acute pain and anxiety in children undergoing medical procedures. It's a multidisciplinary specialty practiced by a wide group of specialists. And most of the literature and research that has been done in this field has been done by emergency medicine, gastroenterology, and radiology. In terms of indications or procedures, we'll start from the most common and then the least common. So the most common are diagnostic imaging, CT and MRI, orthopedic procedures, primarily fracture reduction and dislocation reduction, and laceration repair in young children. The common procedures include abscess, incision and drainage, lumbar puncture, arthrocentesis, central venous access, bone marrow aspiration and biopsy, gastrointestinal endoscopy, foreign body removal, and PICC line placement. I want to just note that PICC line placement become an increasing use of procedural sedation for this area as it's being practiced both in community hospitals and in children's hospitals. And the less common procedures would be a slit lamp examination, a chest tube placement, thoracentesis, cardioversion, dental procedures, particularly in the syndromic or the special needs patients, and burn debridement. Now, this should give a broad overview of the myriad of procedures and indications that procedural sedation could be used for, and this list, as you know, continues to expand. I think a more useful way of categorizing the procedures is by non-painful, minimally painful, and painful, because this allows us to begin to match the drug regimen that we're going to use to the procedure. So non-painful procedures would be primarily diagnostic imaging. Minimally painful procedures would be laceration repair, cast placement without reduction, so a non-displaced fracture that just simply needs to be casted in an anxious, apprehensive 2-year-old, slit lamp examination, and then painful procedures, fracture and dislocation reductions, abscess, incision and drainage, lumbar puncture, and bone marrow aspiration and biopsy. So those are the indications. Let's move to the pre-sedation preparation. The pre-sedation assessment is the most critical part of the entire sedation sequence. It's allowing us to do a risk assessment to determine which patients are at risk for sedation, or more accurately, to have adverse events from sedation. Now, this part up front, being able to screen out those patients that are at risk for adverse events increases the safety and efficacy of procedural sedation. So we take this aspect very seriously. It's based primarily on a history and a physical examination, and we will talk about the ASA classification, or the American Society of Anesthesiologists' physical status classification, which is simply a way of using the history and physical exam to stratify risk. And we'll talk a little bit about fasting status or NPO guidelines, because I know this is of concern. So when we look at the risk factors, clearly a patient has a history of obstructive sleep apnea, problems with sedation or anesthesia in the past, an active respiratory infection or respiratory disease, cardiac disease, medication allergies, potentially difficult airway, which could include patients, syndromic patients, or patients with micrognathia, with stenotic or small mouths, patients with difficulty moving their neck or stability of the cervical spine. These are patients who would have potentially difficult airways. Obesity, and obviously patients in renal failure or liver failure must be carefully considered. So these are not absolute contraindications. Some are. Most are relative contraindications. Obviously, if someone has a medication allergy, that's an absolute contraindication, or not a potentially, but a documented from previous instance difficult airway, those would be absolute contraindications. The others are relative contraindications. Now, this is the ASA physical status classification, and you can see basically there's a description of the type of patient that would be in each class, an example, and their suitability for sedation. Primarily, ASA Class 1 and 2, and in certain circumstances, ASA Class 3 are candidates for procedural sedation. Clearly, ASA Class 4 and 5 are not candidates, are absolutely not candidates for procedural sedation. ASA Class 3, in certain circumstances, are candidates for procedural sedation, but not in a normal course of events, and there really has to be a risk-benefit assessment done on each one of those individual patients who is ASA Class 3. So the ASA Class 1 is this normally healthy patient, and the ASA Class 2 are patients with mild systemic disease. In terms of fasting guidelines, we're going to look at the American Academy of Pediatrics fasting guidelines which go by age, and then the type of solid or liquids that's ingested. Under 6 months, clear liquids is 2 hours, solids and non-clear liquids as well as breast milk is 4 hours. 6 to 36 months, 2 hours for clear liquids, 6 hours for solids and non-clear liquids. And if they're greater than 36 months, it's 2 hours for clear liquids and 8 hours for solids and clear liquids. Now, these are for elective procedures, and I want to be very clear about this, that the fasting status is basically determined by the degree of procedural urgency. So, if you have an elective procedure, a patient's being scheduled for that, one should absolutely follow AAP fasting guidelines. However, if you have an emergent or an urgent procedure that needs to be accomplished, and usually this occurs in the emergency department, then this is done, risk-benefit assessment is done on a case-by-case basis. So elective, follow fasting guidelines, AAP. Non-elective, the emergent to urgent, is a risk-benefit assessment. Now, this brings us to the topic of adverse events. And before we start talking about monitoring and equipment, I like to think of that in terms of adverse events basically dictates both what equipment we will need and how we will monitor the patients. So as you know, the primary adverse events are respiratory in origin, respiratory depression, apnea, both obstructive and central apnea, hypoxia, and in limited circumstances, and I'm referring particularly to the use of Propofol, decreases in blood pressure and hypotension can occur. So primarily we're going to be focusing on, with the equipment and the monitoring, how to manage and recognize prevent and manage adverse respiratory events. So the equipment, you need a bag mask for ventilation. Now this can be either an ambu bag or an anesthesia bag, whichever you're comfortable with, but it must be a bag mask. An oxygen source is necessary, and a suction device. Now, the suction device should not be a small feeding tube, even in the infants, the small infants. It should be a Yankauer suction. And the reason for that is that aspiration of clear liquids, as opposed to particulate matter, does not cause chemical pneumonitis that leads to aspiration, clinical aspiration syndrome. It's particulate matter that leads to the chemical pneumonitis and then to clinical aspiration syndrome. So you need a larger suction that can aspirate particulate matter, and that's a Yankauer suction. So you need a bag mask for ventilation, oxygen source, and a suction device. In terms of monitoring, the type and timing of monitoring is determined by the level of sedation. So mild sedation, so we're going to talk about mild, moderate, and deep sedation. So mild sedation, which is primarily anxiolysis or oral analgesia, you just need clinical observation. You do not need mechanical monitoring. So if you're giving oral midazolam or you're giving oral oxycodone, you do not need pulse oximetry, capnography, blood pressure monitoring. Simply need clinical observation, because the majority of these medications undergo first-pass hepatic metabolism, and you lose a large percentages of the drug with blood levels about 30% of bioavailability, about 30%. So as the blood levels never become high enough to have significant respiratory events. So mild sedation does not require mechanical monitoring. Once we arrive at moderate and deep sedation, mechanical monitoring is necessary. With moderate sedation, the vital signs should be recorded approximately every 15 minutes with continuous pulse oximetry and blood pressure monitoring. For deep sedation, the vital signs should be recorded at least every 5 minutes with continuous pulse oximetry and continuous capnography and blood pressure. Now, I want to say one point about capnography, because some of you may not be familiar with the use of capnography for procedural sedation. Capnography is the measurement of exhaled CO2 in breath. It's measured continuously by a nasal cannula or a nasal oral cannula, so it captures mouth breathers and switch breathers for procedural sedation. Now, capnography has been shown in many studies to be an earlier indicator of respiratory depression. It's a direct indicator of respiratory depression and ventilatory compromise than pulse oximetry. And therefore, for deep sedation, it is strongly recommended the use of capnography. And capnography, as I said, in spontaneously breathing patients can be used by a nasal cannula or oral nasal cannula. Let's move now to the Pharmacopoeia. There are 5 classes of medications that I'd like to discuss: opioids, sedatives, dissociative agent, inhalational agent, and antagonists. So if you start with the opioids, there's the first generation opioids, which you're familiar with: morphine, meperidine, hydromorphone. These are histamine-releasing opioids. Therefore, they cause nausea and vomiting, pruritus, hypotension. And more importantly, for procedural sedation, they're relatively cumbersome in terms of titration. So what our ideal goal is to match the drug to the procedure time. So if you have a 5-minute procedure, you'd like to have the drug effect, or the duration of the drug, the onset be rapid, and the offset or the duration be relatively short, so you don't have a 5-minute procedure, then a very long recovery period. So these drugs, the onset time intravenous is somewhere between 3 and 5 minutes, and more importantly, the duration is 1.5 to 2 hours. So these are cumbersome in the sense that they release histamine and have those side effects, and they're a slower onset time, so it's a longer titration, and they last a longer period of time. The second generation opioids, fentanyl and its family, sufentanil, alfentanil, and remifentanil, are non-histamine releasing, short-acting opioids, so with relatively short duration. So, for example, fentanyl is 100 times more potent than morphine. It's dosed in micrograms as opposed to milligrams. Its onset time is 2 to 3 minutes, and its duration is approximately 30 to 45 minutes. So it really more closely approximates the requirements for procedural sedation. I have remifentanil in parentheses there because it is not currently in use in procedural sedation, but I think for future directions we will see the use of this. This is a one-arm brain circulatory opioid. That means it takes effect one arm brain circulation, 30 seconds. It takes effect and it lasts, it's very lipophilic, so it lasts for about 5 minutes before it redistributes to the periphery. So I think there is a place for a very short-acting opioid for very short procedures. And more research needs to be done on remifentanil, so I'm leaving that in parentheses. For sedatives, there are also the first-generation sedatives, which were diazepam, lorazepam. And again, these are sedatives just like the first-generation opioids, which have a longer onset time and a longer duration. Midazolam, which is a second-generation sedative hypnotic, is a shorter onset, 2 to 3 minutes, like fentanyl, and a shorter duration, also like fentanyl, somewhere between 45 and approximately 60 minutes duration. Now, fentanyl by itself, unlike morphine, for example, morphine at low dosing has equipotent analgesic and sedative effects. Fentanyl at low dosing, 1 to 2 micrograms per kilogram, has no sedative effects whatsoever. It's pure analgesia. Therefore, if one is doing a painful procedure for which you need analgesia, but you need some degree of sedation, fentanyl is coupled with midazolam to provide the sedation because at low doses fentanyl provides no sedation. So going back, so that's a very typical combination for painful procedures, fentanyl and midazolam. It's a very safe combination in terms of there are both opioid antagonists, Naloxone as you can see, and benzodiazepine antagonist, flumazenil. So if you run into some difficulty, unanticipated difficulty, you can reverse one or both of these agents. So they have a relative safety margin, and they must be used together for painful procedures. If you want some degree of sedation, you need midazolam coupled with fentanyl. Pentobarbital is an intermediate-acting barbiturate. That means it lasts, its onset is 3 to 5 minutes. Intravenous. It lasts approximately 30 to 60 minutes, I'd say more like 45 to 60 minutes, or sometimes longer, depending on whether you give a single dose or repeated dosing. It's used since it has no analgesic properties, and all the sedatives in that category have no analgesic properties. It is used primarily now for diagnostic imaging. And as we'll see as we go on, that pentobarbital, which was the mainstay for diagnostic imaging in children for many, many years, is now being replaced with Propofol and Dexmetatamidine. So I would say that we're going to see a significant waning in the use of pentobarb and an increase as the increase in the use of Propofol and Dexmetatamidine for diagnostic imaging. Chloral hydrate Let me just say a couple things about chloral hydrate because I think it's gotten bad press. Chloral hydrate, when used for limited indications, is a very effective and safe agent. It is administered orally. It is erratically absorbed rectally, so it must be given orally in the doses of 50 to 75 milligrams per kilogram. It is very effective in children under the age of 3 years. We don't know why, but over the age of 3, it becomes unreliable. Except in syndromic patients, it can be very effective and reliable even into adolescence. And commonly, if I have a syndromic patient, I will ask, and they need diagnostic imaging, I will ask the parents what have they used that has been effective, and many of them will tell me that chloral hydrate works very well for them and continues to work very well, and we'll use that in those circumstances. It is most effective, again, in the children under the age of 2 primarily for head CT. For MRI, it's a little tricky because its duration of action can be sufficient but may not be. It typically takes about orally, depending on what the child has in their stomach, somewhere between 15 and 30 minutes to take effect. And it lasts anywhere, depending on the time of day, particularly in young children, lasts anywhere from approximately 90 minutes to 4 hours, but most between 90 and 120 minutes. Propofol is an agent which really has revolutionized our care of patients in the emergency department and in the operating room, in the endoscopy suite, et cetera, in radiology. It's an ultra-short, a very lipophilic, ultra-short-acting, one-arm brain circulatory drug, onset in 30 seconds. It's off in about 5 minutes. It can be given as a loading dose, a bolus dosing for very short procedures, or a loading dose and then an infusion for longer procedures. It is very effective for non-painful procedures, for head CT, and here's a perfect example of matching the drug to the procedure. The head CT takes approximately 2 minutes from the time the child is in the scanner and the scanner is set up and the scan is done. And Propofol is a 5-minute drug, so you have a very rapid, very effective period of sedation, and then when the procedure is over, the patient wakes up very rapidly, back to baseline. Etomidate is also another one-arm brain circulatory drug. It has the same properties essentially as Propofol, rapid onset, very short duration. It does cause in somewhere between 15 to 20% of the patients varying degrees of myoclonus, so it may not be the best agent for diagnostic imaging. It has no analgesic properties, so it's been used in certain circumstances for diagnostic imaging. It's been used in certain circumstances when coupled with an analgesic agent for painful procedures. Dexmetatamidine, again, I have in parentheses because just like fentanyl, this is a drug for the future that we'll potentially see for diagnostic imaging. It is an alpha agonist that causes no respiratory depression. So it causes sedation without respiratory depression. Sounds like an ideal agent. Has no analgesic properties, so is essentially used for diagnostic imaging. It's given as a loading dose over about 10 minutes and then an infusion. So it's really most effective for MRI. And both Propofol as an infusion and dexmetatamidine as an infusion are really becoming the drugs of choice for magnetic resonance imaging. Moving to dissociative agent, ketamine is a very unique drug. It is in a class by itself. It has both analgesic and sedative properties. It's a profound analgesia, a profound sedation and dissociation. It is a one-arm brain circulatory drug, again, just like Propofol and etomidate. Its onset is within 30 seconds. It lasts about 5 minutes in the intravenous form. It can be given intramuscularly. It is unlike any other intramuscular agent in the sense that the onset of effect intramuscularly is within 60 seconds, with full dissociation within 3 to 5 minutes. So it's very rapid onset also in the intramuscular form. Also lasts a little longer in the intramuscular form, the intravenous form, somewhere between 20 and 30 minutes as opposed to 5 minutes. It's a highly titratable drug in the intravenous form because it's so rapid acting. All these very rapid acting agents are highly titratable because you can give a dose. You can wait 30 seconds to see full effect, 30, 60 seconds. And then if you haven't reached your sedation endpoint, you can give another dose. So it's very easily titratable. The ketamine also in some ways, like chloral hydrate, has gotten some bad press. People are very concerned about emergence phenomenon with ketamine. This is a very rare instance in children. Also, concern for laryngospasm. This is also very rare in children. Any drug in stage 2 anesthesia. So when you get them to a deep level, any of these drugs can cause laryngospasm. It's not just ketamine, so I wanted to mention that. Ketamine is probably the most commonly used, other than midazolam, as an intravenous procedural sedation agent in children. Ketamine is probably the most commonly used agent, which has both analgesic and sedative properties. What about nitrous oxide? Nitrous oxide is a weak analgesic. It's a weak sedative and a weak dissociative agent. So one must, in order not to be disappointed with the use of nitrous oxide, which is used in a mixture of either 50% nitrous oxide, 50% oxygen, or 70% nitrous oxide, 30% oxygen. In order not to be disappointed with the use, you have to understand very clearly its indications. It can be used effectively for frightened children who need intravenous catheterization placement. It can be used for Foley catheter placement. It can be used for small incision and drainage of small abscesses. I would say that the larger abscesses, where you need to break up the loculations and express a significant amount of pus, will require systemic sedation with parenteral agents, but nitrous oxide works well. Now, in conjunction also with, for example, a hematoma block in a teenager, nitrous oxide is very effective for fracture reduction in terms of providing sedation. The analgesic, the antagonists we discussed, there is the specific opioid antagonist, naloxone. Rapid onset can be given both in the intramuscular, intravenous, and, as you know, in the intranasal form. Now, you may have read in the newspapers that many EMS systems are carrying intranasal naloxone. Fumazanil also may be given intramuscularly, intravenous. It's a specific benzodiazepine antagonist. One should be very careful on the administration of fumazanil to make sure that the patient is not using benzodiazepines, because this will cause withdrawal. So this goes through the 5 classes of agents, and I wanted to move from here to discussing them by routes of administration. And you can see that I've highlighted which agents should be used, can be used in the office, and I wanted to kind of go through that. The topical agents, as you know, topical analgesics have revolutionized our laceration repair in children, and also our use of them for lumbar puncture, for intravenous catheter placement has been very effective. So there are 2 types, as you know. There are those for intact skin, and that's EMLA, or eutectic mixture of local anesthetics, 2.5% prilocaine, 2.5% lidocaine in a cream base, has been very effective for lumbar puncture, as I mentioned, for intravenous catheter placement. The problem with EMLA is that it takes 60 minutes to take effect, and you can't cut corners. You can't put it on and say, well, after 30 minutes I'll take it off and do the procedure. It really takes 60 minutes for effective analgesia. There are delivery vehicles for topical anesthetics of the EMLA compound that cut down on the time. For example, you can use heat, you can use ultrasound, you can use electricity to drive the lidocaine molecules through the skin more rapidly than just placing the cream on. One of the more effective means at this point is using a patch, which it's called a Sonera patch. Many of you may have seen this patch. The patch basically, when you activate it, when you take off the covering, it causes release of heat, and the heat drives the lidocaine molecules through the skin. And so instead of taking 60 minutes, it takes about 20 minutes. So now at this point, if you have the time, EMLA is fine. If you want to begin to look at less time, I would look at some of the other ways of administering the topical anesthetic. LET, or lidocaine epinephrine tetracaine, is for broken skin only, therefore for lacerations. Very effective. There are really two indications for LET. One is for laceration repair, and the other is for burn debridement. So if you have a small area of a burn, or you have some road rash that you want to clean, the application of LET is very effective in terms of anesthetizing that area topically. It takes about 20 to 30 minutes to take effect. It comes in three vehicles. It can come as aqueous, and this is all dependent on the lidocaine component: aqueous, gel, or viscous. I highly recommend the gel or the viscous because most of these, as you know, in the young children are facial lacerations or scalp lacerations, and so you want the topical anesthetic to stay in the laceration. So if you've got the aqueous, it's just running all over the face. It's not very effective. So you want the viscous component or the gel component of the lidocaine. These are not made commercially. They're made by your hospital pharmacy. Each pharmacy has a different formula for making it depending on the concentrations of each of the components of the lidocaine, epinephrine, and tetracaine. There are two ways, I think, to really apply the LET. One is if you really need to be able to move effectively and see other patients while the LET is taking effect in 20, 30 minutes, you can impregnate a cotton ball with the LET and then apply that to the laceration and then put Tegaderm or a Band-Aid or a piece of tape over there, send the child out to the waiting room, and then after 30 minutes, bring them back in for the laceration repair. Now, how do you know that the LET has taken effect? It's very straightforward. You'll get significant vasoconstriction around the wound. So when you remove the cotton ball, you will see an area of vasoconstriction that surrounds the wound. If the wound is in one spot and the vasoconstriction is in another spot, obviously you need to reapply. One of the things that I do is that, particularly in anxious or frightened children, I will take a Q-tip, desensitize them to the Q-tip. Here, can you hold that Q-tip? Yes, I got a Q-tip. We'll play a little swords with the Q-tip. Then I'll apply the LET with the Q-tip. And then I'll come back every 5 minutes, see other patients, come back every 5 minutes and apply that for about 20 minutes. That both allows me, particularly if it's a two-layer closure, to anesthetize the outer layers, and then as that takes effect after about 10 minutes, to go in and apply my next applications in the deeper layers. And it also desensitizes the child to my touch, so by the time I'm going to apply the local anesthetic, if I need it, or I'm going to start the repair, the child is not paying attention to what I'm doing. I also should say that in many circumstances, in areas of the face where the tissue is relatively thin, particularly the periorbital areas, or very superficial lacerations, local anesthetic is not necessary. Simply good application of topical anesthetic is sufficient to anesthetize the wound. In terms of oral medications, oral midazolam can be used in the office. It's a very effective anxiolytic agent. You're not going to get significant sedation with oral midazolam because you lose 70% of the drug in first pass hepatic metabolism. But it's a very effective anxiolytic. Child, particularly in two circumstances. One is children between 1 and 2 years of age who you're seeing and it's past their bedtime and they need just a little bit something to put them to sleep, to have them relaxed enough to go to sleep. It's an effective agent. I commonly use it in these age group. I apply the topical anesthetic for a laceration repair, have the parents give the child a dose of the midazolam, come back, tell them to get me when the child falls asleep. Child is put on their back, they fall asleep, and then I can do the laceration repair painlessly. Another agent for which I'm going to come back to midazolam in a second, another agent for which you can use the same technique, children between 1 and 2 years of age who have a laceration, it's past their bedtime, you can use 50 milligrams per kilogram of chloral hydrate, very effective agent. They'll go to sleep. They have the topical anesthetic on. You can suture them painlessly. Back to midazolam. Midazolam can also be used. So one circumstance is the 1 to 2 year old laceration repair. The other is in the older child, let's say between 5 and 10 years of age, who's extremely fearful, particularly whose anxiety is out of proportion to the situation. Either they've had a bad experience, a negative experience in the past, or they've been told something that's got them very anxious about what's going to happen. I don't want a needle, what's going to happen? In that circumstance, oral midazolam is very effective in terms of an anxiolytic. And then you can, once they sort of, when you first see these children, they sort of have a force field of anxiety. You know, your words are kind of bouncing off. You can't make contact with them. A little bit of oral midazolam, come back 20 minutes later, and they're relaxed, and you can begin to make contact and initiate the procedure, etc. So a very effective agent in the office. Intranasal is a route of administration that we used in the 1990s, which was very operator dependent then, because we'd take a tuberculin syringe and we'd do drop by drop in a child's nose. And if the child swallowed when we put it in, it would be an oral dose, or if they coughed and sputtered, then it would not take effect. So it's very operator dependent. Now there is a device called the mucosal atomizer device, or MAD, which is essentially a small device that goes on the head of the syringe and basically aerosolizes into a metered dose the medication. So now you can have a much more effective delivery vehicle for intranasal administration. And this has really revolutionized our ability to use intranasal medications. Intranasal medications have a particular advantage because they have a much higher bioavailability than oral medications. Again, where oral medications, the bioavailability is about 30%. Intranasal medications, the bioavailability is somewhere between 80 and 90%. So you get a lot more bang for your buck. And these kids, therefore, should be monitored in the moderate sedation category as opposed to the mild sedation category, because they can get significantly sedated with intranasal midazolam, or they can get significant analgesia and some sedation with intranasal fentanyl. I also mentioned, as before, that Naloxone, particularly by EMS, can be used intranasally. Fentanyl can be used intranasally for pre-procedural analgesia. So if we have a child who has a fracture or even a dislocation and they need to wait a little bit before they can have the reduction, they will get intranasal fentanyl either in triage or when they arrive in the exam room, and then after they have pain relief they can get their IV, etc. So it's a rapid way of delivering pain relief. It's very safe, very effective. Ketamine we discussed, both in the intramuscular and intravenous form, is very effective, as well as fentanyl and midazolam. Propofol can be used by itself for non-painful procedures or also for dislocation reductions. It's very effective in terms of muscle relaxation and sedation. But for any painful procedure, I have there Propofol Plus, so it needs to be used with an analgesic agent. And there are really two analgesic agents that Propofol can be used with, just for your information. One is Propofol plus fentanyl, and the other is Propofol plus ketamine, which has become known as Ketofol. Both have advantages and disadvantages. Basically, there is more synergistic respiratory depression with Propofol and fentanyl. With Propofol and ketamine, there's shorter recovery times. In terms of which ultimately is the safest and most efficacious, the research is still pending on that. I think we know that they're at least equivalent. It's hard to say at this point one is a better agent, one is a better regimen than the other. But they're both very effective. Nitrous oxide, we discussed. I didn't put nitrous oxide as an office med, but I don't see why it couldn't be used in the office. There are now portable nitrous oxide delivery systems. They used to be these big systems with an oxygen tank and a nitrous tank that you had to wheel around. Now they're very small portable systems that can be used in the office. The dentists, as you know, have been using nitrous oxide in the office for many, many years. There's no reason why in your office and pediatrician's office you couldn't be using nitrous oxide with proper training. It's also important to remember that you also have to have a scavenger device there so you don't have nitrous oxide leaking into the environment. So there's certain environmental requirements you need for nitrous, but that's all built in to and comes with the nitrous setup. So this goes through basically the pharmacopoeia and the routes of administration. I want to say one other thing about premedication. So in terms of premedication, we discussed you can use midazolam orally, intranasally, or if you have an IV intravenously. For pain, we talked about intranasal fentanyl and intravenous fentanyl, but also oxycodone is a very effective agent for pre-procedural and analgesia. So something to consider that can be given in triage. It's a very safe and effective medication. Please note that I do not have codeine or codeine products here. We no longer use codeine for two reasons. One, it is a relatively ineffective analgesic. In fact, some studies have shown that it is no more effective analgesic than ibuprofen. It also has side effects in terms of constipation. Well, all opioids cause constipation, but children can get quite nauseous with codeine. So it's not an particularly effective analgesic. It causes nausea, and there's a selective group of metabolizers who metabolize it. It's metabolized to morphine, and the rapid metabolizers can run into problems if they are a rapid metabolizer with essentially an overdose, morphine overdose from taking codeine. So in our hospital, it's been taken off the formulary. I know this is the case in other children's hospitals. I would recommend strongly the cessation of use of codeine and moving to oxycodone and even hydrocodone. The problem with hydrocodone is it's very difficult to find this in liquid form. And for the young children under the age of 5, you want to be able to give it in the liquid form. Even oxycodone is difficult to find in the liquid form. Only certain pharmacies carry it, but it's a very effective analgesic agent. Just to talk about matching the drug to the procedure, here you can see the non-painful procedures. We discussed chloral hydrate, Pentobarb, as we talked, being phased out for diagnostic imaging. Propofol, fentanyl, and midazolam is an option for non-painful procedures, particularly for CT scan or diagnostic imaging, where you're unclear whether the patient has a difficult airway or not, and what will happen if you decrease upper airway muscular tone to that patient. So if you have any concern, particularly in the syndromic patients, you may want to think about using a reversible agent regimen, and that would be fentanyl and midazolam. So just to be clear again, in syndromic patients who sometimes have their tongues are proportionally larger in terms of the surface area of their mouth, who can have a obstruct very easily once you've taken away their upper area muscular tone from sedating them, you may want to think about using a reversible agent combination in that circumstance. For minimally painful procedures, laceration repair, minimally painful in the sense of you can ameliorate the pain with local and topical anesthetic. We talked about midazolam, oral intranasal, fentanyl intranasal, fentanyl midazolam, and propofol. And then for painful procedures, fentanyl midazolam, ketamine in its routes of administration, and propofol with fentanyl or propofol with ketamine. I want to just mention one thing about ketamine. Those of you who have experience with ketamine or know about ketamine know that in the beginning we were using ketamine in combination with atropine because we thought that ketamine was a potent sialagogue and we needed an anti-sialagogue to counter that effect. And we're using it with midazolam to blunt emergence reactions. We now know from some good literature in emergency medicine that both these agents are really not necessary. Ketamine is really not in our environment in emergency medicine or in gastroenterology. I would say outside of the operating room where we're using lower doses, single agent ketamine, it really doesn't have potent sialagogue effects. And if it does, I use a low-tech approach, which is if I see the patient begin to salivate, I suction. Midazolam has really not been shown to be very effective in our environment because the emergence reactions are so rare. So now we give ketamine by itself. We no longer use atropine and midazolam, just to make that point. So now you've screened out those patients for high risk for sedation. You've sedated the patient. You've been prepared for adverse events. You're monitoring them. You have all the equipment, etc. The sedation goes very well. Now you recover them. A couple of things about recovery and discharge. Please note that according to AAP guidelines, the child does not need to be able to walk unaided or to be able to drink. This is very important, and I'll come back to this in a second. They need to be alert, back to their age-appropriate baseline. Sometimes this can be very difficult. If you sedate a child late at night, it can be very difficult to have them fully wake up and back to their baseline at 2 in the morning. They need to have stable vital signs. They need to be able to talk. They need to be able to sit unaided, if age-appropriate. And you need to give the accompanying adult written discharge instructions. They do not need to be able to walk unaided. So they can have truncal ataxia. They can have gait ataxia, but they can't have truncal ataxia. So a parent, as long as the child is back to baseline, a parent can pick the child up and carry them out to the car to take them home, and that is not a concern. I often tell parents that if they put the child in the car seat, particularly if it's at night, they should be very careful about this because they want to have some adults sitting in the back because if the child goes to sleep and kinks and obstructs, they want to just be able to lift the child's head. They do not need to be able to drink. This is very important. All this will do is prolong their stay in your office, in the emergency department. This comes from the PACU, where patients received general anesthesia. They had been fasted for long periods of time. They had received inhalational agents. And then they come out and when they recover, they have to be able to demonstrate that they can drink. Particularly, many of the inhalational agents were emetogenic, so they wanted to make sure they didn't vomit. The 99% of the children that we see for procedural sedation are well hydrated. They're euvolemic. They haven't been having vomiting and diarrhea. and they haven't received inhalational agents, so there's nothing to worry about them vomiting in that respect. So they really don't need to be able to demonstrate that they can drink. Very important in terms of shortening the period of recovery and discharge. In terms of future directions, I think we're going to see more use and more research on the ultra-short-acting analgesic sedative combination of ketamine and propofol. And I think that this will supplement many of the use of ketamine by itself and shorten the recovery period and the adverse events. We'll probably see the introduction of an ultra-short-acting opioid, remifentanil, as we discussed, and the introduction of dexmetatamidine for diagnostic imaging as an sedation agent which does not cause respiratory depression. For children who are going to be in the emergency department for longer periods of time, or the introduction of continuous patient-controlled analgesia, I think has a place and will come in the future. So when the child arrives in triage and it's been assessed that they need the following procedure, and it's going to be this time limit, they can receive an IV, they can receive a PCA pump, and they can actually control their analgesia before and after the procedure. And we'll also see, and we've seen and will continue to see, expanding of procedural sedation from the individual specialty areas like emergency department or gastro or the endoscopy suite or radiology into sedation services that serve the needs of oncology patients, hematology patients, patients who need to receive PICC lines, patients who have osteomyelitis, who have a long period of antibiotics, who need PICC line placement to go home, or ruptured appendicitis who's going to go home. So now we're seeing expanding, and we'll see continued expanding of hospital-wide sedation services. So I hope that this has been helpful, and we've covered the 5 areas of the sedation sequence, and including future